cytokines. So I remember we did mention about these proteins, and today's lecture will talk about how the immune system is regulated and what are these small proteins doing, and we classify them and divide them according to the function they have. And then again, like endocrinology, like polypeptide hormones that you normally see there, they have to have receptors. And again, like any other receptor, they also follow a signaling transduction pathway. And many of them are being used in therapeutics, or they're in pipeline, as I mentioned the other day. So we've been talking about cells. And you remember there are some acellular components of the immune response, because the whole immune response needs to be orchestrated and regulated. So regulation will give us a clue as to where we want to lead this immune response towards. As I mentioned the other day, we don't want too much of inflammation, and we don't want no inflammation at all. So there has to be a balance. Inflammation is good and bad. Sometimes we need it. If there's a cut, we need our cells to go over there to take care of the inciting agent and also do the healing. But if it becomes chronic, then again we are in trouble. So anyway, cytokines are important in terms of regulation of immune system. Now, having said that, they are soluble mediators. So they are there as soluble mediators. And there are a bunch of them, I would assume 50 of them. And once you get used to their names, you pretty much will have an idea as to what they are doing. Sometimes, as they say, so if the immunologists are kind on you, they're going to give a good name so you remember it. And sometimes they give it a number. And if you remember, we talk about IL-2 as a growth factor. We talk about gamma interferon. We talk of many other cytokines. But these are low molecular weight proteins. They are produced by cells. That's the important thing. They're produced by cells, and they act on cells. There was a time we used to think that we used to call them interleukins. That's where the IL comes from. And later on, we realized that they not only act on cells, but they also act on cells of epithelium. Initially, it was like cells of immune system. And pretty much both cells of innate and adaptive immune response. Generally, as you saw yesterday's lecture when we said that CD4 T cells are the major players and they will set the tone as to which direction this immune response is going to head towards. So one of the ways that the CD4 T cells will direct this immune response is to produce cytokines. So these cytokines will basically determine as to what is the outcome of immune response. And they will also control magnitude of immune response. And the simple example is if you get infected, you want inflammation there to take care of that infection. But sometimes your immune system responds way out of control, and then we have allergies. So we need to balance it out. So that's what we need to know. What are these chemical messengers? So they have to take a message from one cell to another cell, right? And they will also determine whether a particular disease is going to go towards acute stage or chronic stage. That's also very important. And finally, as I said earlier, in order for them to act on the cells, cells have to express those receptors to bind these cytokines. And when I say receptors, remember one of the key concept forming thing I told you that receptors are expressed on the cells at naive stage. They can be upregulated, they can be downregulated. We have some therapeutic drugs that will add on the receptors, and sometimes these receptors are shed off as well. So these are some of the dynamics of receptor. But nevertheless, in order for them to control an immune response, they will act and be ligated to a very specific receptor. And as I said, we are still learning. There are 50 of them. 30 of them probably are very famous. And I think, if I remember correctly, you may want to go through IL-17, because I did mention IL-17 the other day. And other cells are cytokines are very specific. And also keep in mind that since they act like a polypeptide hormones, so they may communicate with many other systems and tissues, like nervous system. And we are learning. There are many things that are not clear, but we are learning. So we tend to divide these cytokines, as you can see, discovered in 1960. And they have some common functional properties, but some of them are important for us to know. They are proteins. They have short half-lives, and then they are synthesized in bursts. So they kind of ooze out, shoot out. So that's an important thing for us to remember. So cell gets activated, it secretes cytokines, and then deactivation. So that's other important thing. And like hormones, they can communicate at very low concentration. So that's also very important. Very, very important. And like hormones as well, they can either act locally. I told you, like autocrine, they're produced by the cell, then they act on the cell. They're produced by the cell, and they act on the cells sitting next to them, like paracrine. Or they can even act like an endocrine. They are produced somewhere, and then the action is in a distant, far-off area. So they basically can pick up any particular action for their effect. And then again, as acetylcholine receptors, nicotine receptor, muscarinic receptor, all the different kind of receptors. Remember when we talked of autonomic nervous system, we talked about those receptors that can be stimulated, upregulated, blocked. So you have sympathomimetic action, sympatholytic action, and then competitive antagonism, and so on and so forth. So these are all different kinds of drugs that we can also come up with. So they are antagonists as well. And then again, some of them are chemotaxis. For example, if there is an injury at a local site, some of the epithelial cells or tissue cells that get injured will produce these chemical mediators, and they will act as a chemotaxis, will invite other cells that we basically need to come and help to repair, to phagocytose, to do whatever needs to be done at that particular inflammatory site. And then again, they also follow a cascade. So they all follow a cascade. Remember yesterday, the cytokine is produced, it acts on the cell, and the cell then produces more cytokine or a different cytokine. So it's like a sequential as well. So this is a good example for autocrine. You can see it produced by the cell, acts on the cell. Paracrine, produced by one cell, acts on the other cell. And endocrine, produced by the cell and acts far distance like nervous system. But one thing you must have noticed, especially in this slide, what is very obvious in this slide, one important thing which is very obvious on this slide is that you have this chemical messenger, but it needs a receptor there. So you will see over here. So let's say if this is a T cell, it produces IL-2, and IL-2 will be released, but it will not act unless and until there is a receptor for that. That's why one of the activation processes that we discussed yesterday was that normally IL-2 receptor present on the cell surface does not have an alpha portion that can only kick in when these cells get activated. So there is a redundant receptor there. So once you have a complete IL-2 receptor, only then this cytokine will act. Okay? And then again, it does show you that the cytokine is released, but we are looking for different sites in central nervous system for it to act. Now, yesterday I mentioned two important T cell responses, and I said they are going to set the tone of how our immune response is going to be directed towards. One word I introduced, pro-inflammatory. The other I said, anti-inflammatory, right? And both of them have two different types of cells. When I say pro-inflammatory, I'm talking about helper cells called Th1. When I'm talking about anti-inflammatory, I'm talking about Th2. So these are two major classifications that we divide our cells into, and they both are important in terms of taking control of infection, allergy, and immune response. So we tend to divide them into these two major categories. And as you can see from here, on these two columns, so you have like Th1 cells, and then we have Th2 cells. Now, dendritic cells are antigen-presenting cells. They will pick up an antigen, and they will then need to process. So there is something in dendritic cell which will determine or lead the way towards a specific response. And we are learning it. We don't even know. So that's a subject of interest that we want to find out what is the signal that tells a dendritic cell whether it's going to go towards one or the other. So what these dendritic cells do is that in order for it to recruit, for example, Th1 and go towards a pro-inflammatory response, it will produce IL-12. Because we know IL-12 is a pro-inflammatory cytokine. While on the other side, if dendritic cell decides that this has to be dealt, this particular antigen, this particular microbe has to be dealt by Th2 cells, so it's going to produce IL-4. Yeah, IL-4 versus IL-12. This would also tell you that if, for example, this is one of my interests as well in terms of research, is that if I find out that dendritic cells are deficient or dysfunctional, they are not producing those cytokines that they are required to produce, so they may need help. So the help of dendritic cells will add on to those cells these particular cytokines. So pretty much these cytokines will then differentiate in two different pathways. And then Th0 means naive cells, they haven't seen an antigen, so they will start proliferating. So they will pick up that antigen over here, as you can see, and then they will secrete the cytokines. So you can see cytokines are secreted. This is the first signal. They have a MHC over here. This is a macrophage. It sees the protein peptide. There's a co-stimulator. In this case, co-stimulation is via CD40. So remember, CD40 is an important molecule. And this basically has to join with the other molecule, which happens to be CD154, to cause the expression of those receptors that are required. For example, so you can see it starts expressing those receptors over here of all those cytokines that are secreted by Th1 cells. Now the next question will be, How do we know? What are the cytokines secreted by Th1 cells? Okay, and this gives you the list of the Th1 cytokines. We have gamma interferon, we have GM-CSF, we have TNF alpha, we have IL-3, we have TNF beta. So these are some of the important cytokines that were produced. I'll just give you one historical background. As the name suggests, I said sometimes immunologists are kind on you. They're going to give you tumor necrosis factor. This means there is a cancer in a person, and if you give a cytokine, this cytokine will cause necrosis of that cancer. That makes sense? So by necrosis, they will cause cell death. So they are helpful in getting rid of that cancer. Okay? Now, one of the things that you would have observed in a cancer patient, especially terminal cancer patient, is that they become very lean, wasted. And the medical term for that is cachexia. Cachexia, they are very cachexic. They become lean, skinny, and that is because of TNF, because TNF is basically not only causing, because immune system is producing TNF to kill that cancer cell, but the same cytokine is also killing your other cells as well, right? So there was a time, probably, I would say like early 90s, when they discovered tumor necrosis factor alpha. They thought that they found a magic bullet. So they would just give this TNF alpha to patients and we'll get rid of cancer. But that wasn't easy. But the question was, how much of TNF do we need to give? Because the reason is that TNF is going to activate macrophages. That was one of the functions. When macrophages get active, they may lead to a different tissue injury. So when they did experimental studies, they found out it was more harmful than good. Then I remember myself, when I was a master's student in immunology, I was told at that time that this paper just came out, that TNF is a magic bullet. And then there was another paper came out, it said that it's bad. So then the direction of thinking changed. So they said, okay, if it's too much of it is produced in cancer, let's block it. So one of my chapters for the master's thesis was I was working on drugs that will block TNF alpha. And at that time, when I was working on that, we found out that there was one drug that was given to pregnant women, thalidomide. Thalidomide was given. And at that time, when they started giving thalidomide to the mothers, they gave birth to babies that had deformities. And thalidomide was anti-TNF. So then there was big cry over there, because remember, things are not easy. You have to do experimental studies on animals before you start giving to human beings. So this kind of activity in terms of use of cytokine has been very important in research for the last more than 20 years, 25 years. Okay? So you can see from here, generally, Th1 type basically activates macrophages. You can see activation of macrophages. It is involved in hematopoiesis, because once there is a pro-inflammatory response, you need a lot of neutrophils. So neutrophils have to be stimulated in bone marrow. And for bone marrow stimulation, you need a cytokine, which is granulocyte macrophage colony stimulating factor. That's what the abbreviation is, GM-CSF. Some of the drugs like tetracycline and others are going to shut down your bone marrow. So you may have neutropenia. Right? So this thing happens especially for the drugs, because drugs are there to kill bacteria, and as a side effect, they kill your cells as well. So you have to have a very precise balance in terms of what therapeutic tool are you going to use. So in this case, you will see most of the time the activity is, for example, if you activate this macrophage, which is a big eater, and it has phagocytosed bacteria, when it gets activated, it is going to kill intracellular bacteria. Okay? And once we talk microbiology, you'll see that these bacteria have multiplication time in terms of seconds and minutes. So they are very fast in growing. So you have to have cells over there that will quickly eat them up, so to speak. So you can see from here, intracellular bacteria are taken up by macrophages. And out of interest, a couple of days ago, we submitted an abstract in American Society for Microbiology, some work of mine where I wanted to use a soluble CD40 molecule to stimulate macrophages to enhance immune response. So you can see these are all different players. And all the research is based upon this concept that you have to have. So what you would do is that you would separate dendritic cell and you will separate the T cells and want to bring them together and then use those cytokines. And that's what happens over here. On the other side, when you have a Th2 type antigen, IL-4 is produced, Th2 cells come, again the same situation. But you will see in this case what's happening is that Th2 type cells tend to go towards B cells. And remember, when the B cell get activated, they will start expressing BCR receptor on their surface. So you see that's what happens. Okay? And then what they would do is that the more antibodies are expressed on the B cell, the more toxins can be taken care of. Once we talk of infection, you will see some of the bacteria cause problem because of their cell wall. Some of them cause problem because of the exotoxins they release, right? So these exotoxins then spread out in the blood. So you need antibodies to neutralize them or agglutinate them. So in this case, you can see that the more antibodies are there, the more toxins can be neutralized or immobilized. Right? So that's why if a person comes, snake bite, venom bite, this bite. So what happens is that there's a toxin there, it's neurotoxic. It's going to cause problems, so you have to give immediate antibodies. So antibodies will basically go and bind those before they cause damage, as simple as that. Okay? Again, BCR, pretty much the same thing. And then you will see CD40. So you will see CD40 basically is one of the important receptors that you need to have in terms of a very specific Th2 type response. Now, what are the Th2 type cytokines? IL-4, 5, 10, 3, and TGF-beta. So you will see that most of them activate B cells. That's what you see over here. And they work opposite to Th1. Remember I told you that if this causes inflammation, this will cause anti-inflammation, right? So you basically inhibit macrophages, right? And then inhibit monocytes, because if you inhibit these major monocytes and macrophages are antigen-presenting cells, but they are also phagocytes, so they will go and eat up the bacteria. So they have this capability, right? So if you stop that, it will be opposite. But again, having said that, keep in mind that sometimes we need a Th1 type response, and sometimes we need a Th2 type response, and sometimes we need kind of a balance between these two. Now, one of the things I mentioned earlier is that cytokines also set a tone whether, for example, there is a, let me show you a picture, maybe that will be better to look at. So what has happened in this case is that, let's say there is an injury in the tissue, and of course tissues are supplied by the blood vessel. Keep in mind, all the cells of immune system are always running in the blood flow, right? So they're patrolling. Unless and until there is a command, there's an order for them to go to a particular site, they would not do so, right? So in this case, what happened is that there is an injury, and this injury releases one of the cytokine, which happens to be IL-8, and which acts as a chemokine. So this is a signal for neutrophils that you need to come out of the vessels and help us out to take care of this injury. So neutrophils will then move from the vessels to the tissues, right? Now remember, that's not that easy because the blood is flowing with a speed. So if you know I'm pretty sure you know cardiovascular dynamics, that if the blood flow is flowing, the main stream of the pressure is in the middle. And as we go to the side, it kind of slows down, right? So most of the time, the cells are moving in the middle. So then there is a chemotactic factor. It will cause rolling of these cells, and they will attach to some of the receptors on the sides, and then slowly, by a process of diapetes, where these neutrophils will kind of snugly, squeeze out of the vessels and go into the subepithelial tissues. Because like boil or any injury, when there is if I cut a boil and there is a pus there, what does it suggest to you? Infection, right? But what actually is pus? They are dead neutrophils. So they are dead neutrophils and of course dead bacteria as well. So neutrophils are there. That's why you have to have plenty of neutrophils. That's why if you have infection, if I go and look at your blood profile will say increased neutrophils. So I would see in your profile that your body is producing more neutrophils. Does that make sense? Okay. So in this case, remember we talked about adressins and other things, and the same concept is important, for example, atherosclerosis as well. Same concept is important. Remember one of the, what is the best-selling drug these days? What is the number one best-selling drug? I think 2014. Let me ask you. Best-selling drug in the world. Number one best-selling drug. Louder, yeah? Hydrocodone. Lipitor. Well, statins. I'll take Lipitor. Statins. Lipitor is one of them. Statins. So there's a big problem there. So one of the actions of statins is that it will prevent neutrophils going towards the site of atherosclerosis, because neutrophils will go over there and increase the bulk of atheroma and will cause blocking of arteries. And there is a long process, but of course, this is one of the actions of Lipitor or any other statins. These are called statins. Okay? So imagine that they are of a good use. Okay, there is a list of, I think in your book, and I'll just quickly go through that because I think this is about time that you start looking at it, just get used to it. So you can see that we have a functional categories of cytokines, and this is from your book. And you will see all the way from IL-1 to IL-18, 23. Each one of them basically is produced by either T cells, B cells, or macrophages. Number one. Number two is that each one of them has a major function. And you can see it may sound, tedious for you, but the fact is, once we start talking about etiology and immunopathogenesis of disease, you will see what is going on in a particular disease like arthritis. Right? So there is too much of pro-inflammatory response. You want to stop it. Right? So one of the things that you may want to do is that you want to block those cytokines, block those receptors, and so forth. So you will see that they have a very specific action. Like for example, just to give you an example, one of what do you guys take for allergy? What's the common drug over the counter for allergy these days? One at a time, yeah. Say it, raise your hand, yeah. Say it again? Louder. Yeah. Say it. Louder so that I can hear. Benadryl. Benadryl is antihistamine. Talk of something more specific. Huh? Zyrtec. What is Zyrtec? Well, antihistamine is a very broad action. But what I'm trying to get at, most of the drugs that you will see expensive one, like chromalin and others, they are mast cell stabilizers. And we'll discuss that in detail when we talk of allergy. Antihistaminic is a general thing. But we are using very specific, and they're very expensive drugs. So you can see from here that IN9 causes mast cell activation. If you activate mast cell, you're going to cause allergy. So you want to block it. So that's where the drugs are coming from. Sometimes we need to give you a drug which will block those cytokines. And many of these are available in different forms in the market. And you can see all the way from growth factors like IL-2 and IL-18. As I give you an example, for example, tooth extraction, you want to fill in the gap, and you want the tissue to heal, gums are damaged, so you want to put a cytokine there that will call in other cells, cells like macrophages and monocytes, which will come and repair. Right? So these are some of the important things that we normally look at. So I would encourage you, but most of the time, either are they going to be pro-inflammatory. So I gave you an easier table in figure 11.2 where you have Th1 type cytokines. I usually ask that. And then you have Th2 type cytokines, right? And you have to make sure they are different, right? And these 10 or 12 are something that you must know because they will come over and over again, okay? Now, remember that one cytokine by itself, you just remember IL-17, but it comes like a family. It's like a family of cytokines. And you can see that like antibodies, they have a family member, they have a molecular weight, they have a percentile homology, and then they have very specific cellular sources. So you can see that as we are developing those scientific methods and we are finding that out in detail. For example, TNF was TNF, and then we found out TNF alpha, TNF beta. So they are like different depending upon which chain of amino acid is there. But you can see from here a little bit of difference in terms of molecular weight, and they have A, B, C, D, E, F, so on and so forth. So as we improve our knowledge of the cytokines, because remember, we need to be very specific when we give it as a source of drug to the patients, okay? So one way of remembering cytokines is that you can have Th1 type cytokines and Th2 type cytokines. Then there are other ways of remembering cytokines. I think your book talks about that, so maybe spend some time on that. These are called functional categories of cytokines. So you can see, depending upon what function are we talking about, if we say, what are the cytokines that facilitate innate immune response? And just like if I was to ask a question, I'll rephrase it, what are the cytokines facilitating innate immune response, and I'll list them all. Right, so we'll have IL-1, IL-6, TNF alpha, interferon gamma, interferon beta. So these are the cells. What it tells you that these are cells which basically have a non-specific immune response. Now, on the other side, if you pick up cells that regulate adaptive immune response, because adaptive immune response comes later, and that's where you want to determine the intensity and duration. It's more specific. So you pretty much are looking for expression of those selective receptors. So you basically are talking about Th1, Th2 type cell. This is more of a specific response because when we talk of, for example, Mycobacterium tuberculosis, and some of the other intracellular infections. So you will see the body deals with them in a totally different way. Okay? So we can categorize them according to their function as well. And some of the other, for example, effect of cytokines is, apart from promoting inflammation, some of the cytokines can basically go and inhibit the lineage-specific T-cell differentiation. For example, they can go up like IL-4, IL-10, IL-12. So if you give them to dendritic cell, you can pretty much determine whether you are going to get Th1 or Th2. So you can go and treat the problem at a higher level. So in this case, we talked about some of the cytokines that can stimulate hematopoiesis. And these are the 3 cytokines. And CSF stands for colony stimulating factor. So our colonies of cells, which are there in bone marrow, they need to be stimulated. That's why we have these 3 cells, and the IL-3 is there. And some of the cells, again, remember I gave you an example for the neutrophil. The neutrophil is running in the vessel, and simple physiological steps were they will move from the center, move to the periphery, attach to the endothelium, and then stick to endothelium, and then move, pass through the endothelium, and go where they are needed. But that's not that simple, right? Because there are receptors there, and these receptors have to be expressed. Some of the receptors have to be expressed on endothelium, and some of the receptors need to be expressed on neutrophil. And I think a simple example is over here. So you can see that these are some of the events that you normally see, A, B, and C. If you pay attention to event A, you see initially there is a weak binding of selectin ligands on neutrophil to E-selectin endothelial cell. So we have E-selectin expressed on those endothelial cells. And I want you to keep in mind, keep your mind open. If I'm giving you this example that there's an endothelium and there is an E-selectin and the cell need to attach to it, keep in mind that sometimes we need the cell to attach over here because we need neutrophils to pass into the tissue. On the contrary, sometimes we do not want that. Like in atherosclerosis, in the heart, we don't want neutrophils to go and block. So the drugs for that will be opposite to that. Sometimes we want to stimulate, and sometimes we want to inhibit. So in this case, E-selectin, it's just like a rope that it kind of throws on the neutrophil and then entangles the neutrophil over here. But this over here is basically considered a weak binding. So you can ICAM, which is intercellular adhesion molecules. Somebody was asking me what are these ICAMs and ITAMs, totally different things. So these are adhesion molecules. So you can see from here, they attach to these over here, right? And then the next step is that IL-1 and TNF alpha, they basically upregulate. Remember the role of the cytokines were that this is a weak bonding, not good enough for neutrophils to be attached. So we need to have IL-1 and TNF alpha. And what will happen is instead of 1 E-selectin, we have upregulation of E-selectin. So we'll have 3 in the presence of these 2 cytokines. And then we can also have dimerization. We call it dimerization of integrins. So integrins are there like 2 hands. So they cannot possibly attach to the receptors. You have to bring them together. So you have to bring them together, and then still you can see it's just like I want to grab these keys and my hands are like this. My receptor is like this, but it's not good enough for me to pick up a bunch of keys. So I would rather have them placed like this, so I can go and grab that, right? So if you pay attention to the C where activation takes place, so number 1 event, what happens is that E-selectin binds with the selectin, and then this one basically turns around And there's a proper dimerization for that. So instead of this way, it is like holding position, and it will hold on to ICAM. And then there is a IL-8 receptor. IL-8 will attach to it. So you have to have at least 3. It's just like, you know, if it's a casual door, you just have 1 key. If it's really important, you have 2. If it's really, really important, you have 3 keys. So we don't normally want our neutrophils to come out of our vessel and cause damage, because neutrophils carry bleach. Neutrophil carries a pharmacy within themselves. They are killers. So if you send them to the tissue, they will cause problems. So we want to make sure that we allow them to go after these 3 processes minimum before we let them go and attach. So this upregulation of those particular receptors is under the control of, if I ask you, what are the 2 cytokines which are important for the neutrophils to be transported to the site of injury? So what will be those 2 cytokines that I'm talking about? IL-1 and TNF-alpha. TNF-alpha. Because IL-8, if you remember, was a chemotactic factor. It was already there to begin with, because that is the one that sent the signal out to neutrophils to tell them, hey guys, come over here, we need to get this work done. They were just kind of call in. Okay? Now, I think you've got an idea that even if you have, so you have to have receptors. That's the whole idea. You have to have cytokine, you have to have receptors, and then again, sometimes we categorize them. You can see from here, these are some of the chemokines. I just mentioned IL-8, but this is an important chemokine. I'm going to talk about the chemokines when I talk. Right now, you may not know it, but one of the things that we get in AIDS infection for HIV, chemokine receptors are involved. Just to give you a heads up on that. So these chemokine receptors are important, and there's a list of them. Okay? So they are produced by these cells, and then they have a very specific message to attract chemically other cells. So if you have IL-8, this is produced by these cells, and they will call in neutrophils and naive cells, and this is what their major function is. So there's a good reason, because if you have an injury, that's kind of beautiful way of calling in. So the cells will only call those specific cells that are required. They would not call any other cell. For example, if there is a worm infestation, and the body knows, that's why you have to understand the immune system. To prescribe a medicine without knowing what the immune system is doing will be injustice, because you are kind of messing up with the nature without even knowing the nature. So you really have to understand what is it offered by the body before you give something out of the body. And sometimes you mess up the whole thing, because body was good enough to take control of it. So we need to learn what is normal body's immune response. So in short, it's like there's a pharmacy already there within yourself. There are antibiotics already there. There are hormones already there. There are steroids already there. There are blockers and so on. So we are learning day by day. And if there is deficiency, then we'll come in and intervene. But our intervention basically requires our profound knowledge for that. And you can see from here, they have a lot of different functions. Right? So this is something we call signaling. Okay? Now also keep in mind, because as pharmacists, we are interested in developing drugs to those receptors. So we want to know what are those receptor proteins, because I need to block it. If I want to help you that you don't get your arteries narrowed down, I don't want your neutrophils to be attached to your cell, cause problem, I want to block those receptors. How would I block those receptors? I need to know what are the structure of protein. I need to know what is it that is required for me to block it. Now, you will see that there are 5 classes of receptor protein. Ig superfamily receptor, you are familiar with that. It's like TCR, BCR, immunoglobulin. There is class 1 cytokine receptor family. Class 2, TNF itself has a superfamily, and there are chemokine receptor family. So what's happening is that these are proteins. They have a structure, right? They have a sequence of amino acids. We have to develop drugs. So we are going to target. And we need to know where are they placed, how do they look like, and what will be the signal transduction pathways after that. For example, you can see from here, this is the structural feature of 5 types of cytokine receptors. And you can see from here, like there's an immunoglobulin superfamily receptor. So this is one of the, and this more of like a immunoglobulin where you have globular kind of proteins with disulfide linkages, you can see from here, right? And this will have a ligand, and each one of the receptor will have a corresponding ligand. The other one is, you can see class 1 cytokine receptors and class 2 cytokine receptor, and they have conserved cysteines there. So because of those conserved cysteine structural things, they are different. And there are some other genetic coding we will not discuss over here. Then you can see TNF receptors are totally different. And we have chemokine receptor. This one is called serpentine receptor. It looks like a snake, serpent. It's called serpentine receptor. And G protein signal transduction pathway. I think I would not teach you that, but I'm pretty sure I thought maybe like 60% of drugs that are right now acting on the receptors touch the G receptor coupling and G receptor pathway, and that basically is coming from serpentine receptor. It's like a snake, and it's going to go to, we call it G protein signaling. So once you activate these particular receptors, they all have a signaling pathway. They have the attachment. They will go in different directions. Okay, so that's what we are, that's what the drug development is. That's what is the research in terms of what are the new drugs in pipeline. So we need to really go in detail, and you can see each one of them has a respective family that the cytokines will go and attach. So if you want to give a TNF alpha, you want to give an IL-8, you have to make sure that it does have a corresponding receptor there. If it does not, it's not going to help you. So if you want to go a little bit detail, you will see that there are structure features of class 1, for example, cytosine receptor, that share a gamma chain that mediates intracellular signaling. So you will see that they all are different cytokines. You see on the top? They are IL-2, IL-4, IL-7, and they have these different ligands that need to be attached. And you will see there are some similarities and some dissimilarities. I just talked about cysteine residues. So that's where we have to target the drugs that we have. The other example that we discussed earlier as well is two forms of IL-2 receptor. Remember, normally if you have an IL-2 receptor which has a beta and gamma chain, it has a immediate affinity. So even if you have IL-2 in the circulation, IL-2 would not attach to it, right? So you need to upgrade it. You need to add another alpha molecule, because that will change the affinity constant, and then again it is going to be expressed on activated T cells. So you can see that when you add a particular structure to that, this will upregulate it. For example, you have T cell, your T cells are not killing cancer, because there's always a predisposition for all of us to develop cancer. Most of it is taken care by our T cell, and sometimes the T cells are not taking care for it, then we need to do something, okay? And there are some final slide, I don't need to remember that, but just I'm not gonna ask you even, but remember that once you stimulate the cytokines, it goes to a signal transduction pathways, which are different than B and T cells, right? And these are some of very specific drugs that are there in the market that will work on JAK kinases, STATs, and so on. So they are very specific molecules which are out there right from the beginning to the receptor blockage, all the way to the signaling pathway. You need to know them in detail. But right now, I think objective for this lecture is, so you should get used to knowing it. It's like they say that eyes don't see what mind doesn't know. So just kind of start thinking that this is what happens. And if you ever want to go and research into it, you will have a little bit of basic idea that how are we going to deal and what are the options available. And then there are some other slides. I would leave it on you, but I'm going to come back again. Signaling pathway, and it's not expected that you should know, but definitely when I will come and talk about role of cytokines in disease, when I'll pick up those specific bacteria, all these gram-positive and gram-negative, I would definitely talk about that in detail. But I would encourage you to just get the basis of whatever information is presented in this lecture.